Started, we are a little behind idea on food systems, food. Please get in touch with us. We'll be interested in hearing from you what you think. And finally, before I hand over to the presenters of the study, one point I would like to make, and that is, while there is a lot of recognition, at least now, on the four groups of conditions and mortality that it accounts for, there is less discussion on the other NCDs, which accounts for most of the morbidities, the mental, neurological, rheumatic, connective tissue, autoimmune disorders, and all the rest of it. So, the global health field is notorious for crowding each other's out sometimes, and this is a red flag, where within the NCD debates, one part of the agenda should not be crowding out the other part of the agenda. So CDC's agenda looks more balanced, and balanced to me at least. Now with these few words, let's get the session started. This is a technical session. The first presenter is Dr. Ali Mehedi, who is the project leader of these health policy initiatives. And then the next presentation will be on surveillance, where Professor Udaya Mishra will be presenting, but also I want to recognize Professor Rajat on the dais, who is also co-author of the study. So let's get started. Ali, the floor is yours. You have 15 minutes time. And like always, ICRIER is very organized. They have given me tickets to tell you how much time you got. And so it has made my life easy. So thanks, ICRIER. Over to you, Ali.
Thank you. Thank you, Dr. Chatterjee, for the dais. I just want to briefly highlight that this is what we're going to present now is the year one of our research under the research program on tackling chronic disease in India at ICRIER. So the first session was about what is happening in the larger ecosystem in terms regarding chronic diseases. So this session will showcase the work that we have done within ICRIER on chronic diseases. So I don't have to present data on the prevalence as such. I'll straight away pick up from where Dr. Bekedam left and highlight the issue of premature mortality due to NCDs. So while the number of deaths due to NCDs were the highest in China, the number of deaths, the premature deaths due to NCDs were the highest in India in the entire world. So 56% of all NCD deaths in the country were premature. And so this is the main cause of concern. As Dr. Bekedam said, we have to die due to some cause, so the cause itself, in itself is not so much of a big worry. The major point of concern is that NCDs are killing people prematurely, because the progression from risk factors to morbidity, from morbidity to mortality is very high. And this is what is leading to a huge burden of disease. So even from the international perspective of the Sustainable Development Goal Target 3.4, which talks about 1/3 reduction of premature mortality due to NCDs by 2030, if India does not proactively work on it, this global target is not going to be achieved. So the issue of chronic diseases, this is how it comes into the picture. So unless this is tackled in India, even the global target is going to be jeopardized. Now, if you look at the breakup of this premature mortality, 89% of these premature NCD deaths are happening in the 30 to 69-year age group. If you look at the broader, the broader ecosystem of death and disability, again, you see that this is the age group, the yellow bars, which is bearing the maximum burden of death and disability. Whether you look at DALYs overall, whether you look at DALYs due to NCDs, total YLL stands for years lived with years of life lost, which is an indicator of premature mortality. So whether it is total number of years lost, you see 30 to 69 is the focal group. Whether you look at the NCDs, YLL NCDs, again, the 30 to 69-year group is the main contributor. Again, you look at the burden of disability, years lived with disability. Again, the 30 to 69. What I'm trying to highlight here is that we need to adopt a population, a target-specific approach when we talk of chronic diseases. We cannot talk in general, because we have to, identify where the burden of chronic disease is concentrated, and again, prioritize in terms of prematurity. This graph shows us that over time, the overall burden of mortality has shifted from the child, which is the 0 to 4-year age group, towards the 30 to 69-year age group because of increasing life expectancy. So as the country develops, there is health transition, and mortality at the earlier level goes down, life expectancy improves, and then mortality at the higher age groups increases. Now the global target, so then you have the 70+ year line, which stands at 34%, which is not necessarily a bad thing, because if you look at advanced countries, the percentage of deaths happening at the 70+ level stands close to 81% or 82%. So that is something that we have to target, increase the percentage of deaths happening at the 70+ year level, or in other words, reduce the burden of the deaths happening at the under 70 level. If you look at major Indian states, again, you see the main burden of premature mortality is concentrated at the 30 to 69-year level. Even in states like Uttar Pradesh, which are considered, the hubs of child mortality, the burden of premature adult mortality is almost double than the burden of child mortality. So what these states are facing is a double burden of what we have called the double burden of premature mortality, and they cannot simply focus on child mortality exclusively. They will have to graduate and look at adult mortality as well. Now, if you look at this graph, it tells you about the causes of death. The causes of death at the 30+ year level is predominantly chronic. So at the earlier levels, you see that there is more deaths happening due to acute diseases and less so due to chronic diseases. But as a country grows, as there is more development, even deaths at the earlier levels are more due to chronic diseases. This is a fact which is much less appreciated. So normally we tend to associate chronic diseases with higher age groups, but even in earlier age groups, so if you look at the burden of deaths in advanced countries, even the child mortality, you'll see a much higher percentage of deaths happening due to chronic disease. For instance, 44% in the developed countries. So in the coming years, by 2025, 2030, almost 89% of the deaths are going to be concentrated at the 30+ year level. If you juxtapose this fact with reference to the causes of death, you can well appreciate that the burden of chronic disease is going to explode in the country. Add to that the fact that more deaths at the child level will be happening due to chronic disease. So what this means from a policy perspective is that within the next 10 to 15 years, we'll see an explosion of chronic diseases. What we have been talking about is, the current burden or how things have evolved over the past. But this is something that we need to start addressing from now itself, the prospective burden of chronic diseases. So these are the major 8 chronic diseases in the Indian context that we have identified based on their burden of mortality. We differ a little bit from the international focus because internationally, 4 major chronic diseases have been highlighted. But in our own context, these are the 8 major killers. So again, in terms of focus, these are the diseases to watch out for. In terms of morbidity burden, this data is not as reliable as the mortality data, but then again, it can be of help. Some of the diseases like diabetes, they don't really kill you straight away. They lead to other morbidities. And they have impacts, in terms of your health, overall well-being. So in terms of policymaking, in terms of deciding a focus on individual diseases, we should combine the data on mortality as well as morbidity. And for instance, diabetes, the prevalence of diabetes in terms of millions, the projected burden was 66.8 million in 2014 and 69.2 million in 2015, which is 3 times more than the burden of other diseases that we see have a huge share in terms of mortality. Similarly, chronic respiratory diseases have a huge burden. So in terms of deciding, we can also take a population-based approach and look at chronic disease in a more general sense, combining chronic diseases together and looking at the risk factors of all chronic diseases put together. But when it comes to focusing on individual chronic diseases, we'll have to look at both sets of data. In terms of risk factors, again, we differ a little bit than the international focus. The international focus has been on behavioral individual risk factors. Our research shows that the metabolic risk factors, if you put these 4 metabolic risk factors, high blood pressure, high fasting plasma glucose, cholesterol, and body BMI, obesity, these 4 metabolic risk factors together account for more than 50% of the deaths in the Indian context. So while, I would like to highlight this fact here a little bit because it's very easy, it's very convenient to shift on the responsibility, the blame onto the individuals and tell them that, you are responsible for your health. You have to walk more, you have to eat more healthy. But then, where is the responsibility of the government? There are certain metabolic risk factors which can be addressed by health systems only. So health systems have to play a central role in addressing the burden of chronic diseases. We cannot simply, lay our primary emphasis on primary prevention and then, ignore the much bigger burden of metabolic risk factors. And that is where, we say that primary health systems can play a major role. So what can primary health systems do in terms of addressing the metabolic risk factors? The target group, they can do surveillance, they can proactively in the community and opportunistically for the other age groups. You cannot tell those who are facing chronic disease at the 70 plus level you cannot shut them out. But what you can do is you can put your focus, proactive focus on the target group, and then for others you can have opportunistic screening, which is, they can come to the health centers and they can be screened if they want to. Secondly, the primary health systems should treat borderline cases of metabolic risk factors. And like, for instance, somebody has high BP, they can give medicines for that. If somebody is in the initial stages of diabetes, they can address it at that level itself. And then conduct, follow-up periodically with them. Then, as the anchor of health services, they can also refer people to higher levels of care and also coordinate with them. So referral is not only about, sending people to higher levels of care. It's also about coordinating care with them. And people will have to be referred back to primary health centers from higher levels of care. Because if you go visit a hospital, you eventually come back to your home, then where is the fulcrum? Who is the anchor for your care? So primary health systems have to play a central role in terms of, back referrals also. Then again, because the burden of chronic disease will also rise in the child population, and the symptoms can be seen even now, in terms of higher obesity among children, they will also have to ensure continuum of care horizontally. Prevention of not just mortality and morbidity in the higher age groups, but also try to screen for risk factors at the earliest level possible. Now, where do we stand in terms of chronic disease, tackling chronic disease in terms of primary health systems? Now, first of all, the overall spending on health in this country, public spending on health is minuscule, as we have already heard from other speakers. But even within that minuscule spending, if you see, NHM is supposed to be the biggest program of the central government on health. And here, if you see, the flexible pool for non-communicable disease, injury, and trauma is only 2.6% of the entire NHM budget. And if you look at this flexible pool, within this flexible pool, the amount allocated for NPCDCS is only 42%. So first of all, you have very low public health expenditure. On top of that, you have only 2.6% for NCDs. Within that 2.6%, you have 42% going for NPCDCS, which is the main program of the government for tackling chronic disease at the primary health level. Now, that is not the end of the story. Even if you do an analysis of the NPCDCS budget, we did it for the last 3 years, you see that from the proposal to the approval to the actual expenditure stage, the NPCDCS budget keeps shrinking in all these various phases. So for instance, the approval rate of NPCDCS was only 7% for a health advanced state like Kerala. And it went up to 35% it was 7% in Tamil Nadu and 35% in Kerala. Actual expenditure ranged from 4% in Rajasthan to 57% in Kerala and 79% in UP. So I think in terms of priority setting, this gives us a very good picture of where we stand in terms of, we can have a lot of talk, we can keep emphasizing, and the government talks a lot, and they have these programs. But then in terms of actual reality, and mind you, the central government only comprises of 0.3% of the total of GDP expenditure on health. The rest, so 33% of the government health expenditure is by the central government, out of which 26% is by the Ministry of Health, 7% by other central ministries, 66% is by the other states. So now we are talking about 0.3% of the expenditure and how it keeps going down further. So it is not just simply what we have argued in our paper is that it's not just simply about low allocations to chronic diseases, but also it's a matter of priority. So even within the low health expenditures, this is where chronic diseases stand in the grand scheme of things. So first of all, within the existing realities, our recommendations. So in terms of our working paper is much more exhaustive. I cannot cover the entire ground here. So we have made a lot of recommendations what the Ministry of Finance and other ministries can do in terms of tackling chronic diseases. I'm just trying to highlight, some of the major findings that we have, in our paper. There is also a policy brief in your docket, and you can also look at the major recommendations there. Let me just highlight what we have, argued in terms of public allocations to health. So first of all, there is a 27% component for health system strengthening under NHM, the National Health Mission. So we argue that that should not only be used for reproductive and child health, which is for tackling the burden of child mortality, but that should also be used for chronic diseases. Because ultimately you will have to strengthen your systems first. There is a need for a reorientation of health systems towards chronic diseases. So this 27% of the existing, so I'm not talking about increasing the healthcare expenditure. I'm just talking about a slight reorientation in the existing budgets. Then existing allocations under NHM to the states can be made on the basis of both child mortality, which is largely the case at this point of time. Allocations under NHM are made based on child mortality indicators. They should also include adult mortality, where the highest burden of disability and death is at the moment in terms of NHM allocation. So when you are giving money to the states, you should also look at their burden of adult mortality and not just child mortality, which is shrinking over time, and that will continue to shrink. So even in a state like Uttar Pradesh, the burden of adult mortality, as I said, is double than the burden of child mortality. So we have, our allocations have to match the disease profile in the country. We have to, look at the future trends, and this is what is not happening. So even without increasing the public health allocations, if we have a change in priorities in the background of, the evolving disease burden in the country, that can itself do a lot. So I'm not arguing against increasing, but I'm saying it's also a matter of priority that needs to be addressed. Then, of course, eventually, the health sector allocations have to increase, and then under NHM, they have to increase more, and especially for programs which, are focused on chronic disease, because that is where, the main burden is. That is where what is killing people. That is what is causing the burden of disability in the country. Now, again, this is a very dicey thing, because you see, health is legally a state subject. The central government spends a lot of money, but then again, the major share comes from the states itself. This, I think, if you ask me, I would say the biggest problem in India's health sector is not financing. The biggest problem in India's health sector is the delineation of responsibility. I mean, the center has taken a leading role. While the states should have done that, the center formulates the national health policy. The states should have taken a lead on that. So, there is no sense of responsibility. There is, as a result of which, there is little accountability. People don't have a sense whom to go for in terms of, their healthcare. So these are issues which need to be addressed very seriously. So because chronic diseases, call for a long-term commitment of health systems to the people, the local bodies, the state governments will have to play a leading role. You cannot simply rely on the center. Forget the international organizations. The states will have to play a leading role. And that is what, needs to be emphasized. I mean, we keep talking to the central government and the Ministry of Health, which are very tiny players in the entire game, actually. And if you look at the overall health expenditure, 71% of the total health expenditure is out of pocket. So at one level, you also need to be talking to the individuals who are spending out of pocket. They also need to have this change in priority, a focus on, chronic diseases. So it's not just the public component, but also the public, the actual citizens who are spending out of pocket. So moving on from there, governance is something that has to be at the heart of this shift from child to adult mortality. And what we suggest is that the center should be engaged in overall monitoring of the health status of the states, in regulation, and in providing financial and technical assistance to the states as required. Because, there is a lot of lack of technical capacity at the local level. So that is where, the center can pitch in along with, the financial allocations on a need-to-need basis. So right now, the criteria for allocation to the states is, they have this EAG plus Assam, the Empowered Action Group, straight away based on infant mortality. So 284 districts with the highest levels of infant mortality, are preferred in terms of allocations. Also look at adult mortality in that. Then it should be publicly made clear that it is the state government or the local bodies which are ultimately responsible for health. This has to be clear, for all the stakeholders and for all the citizens also. If you go to Sri Lanka, Dr. Siyambalagoda is here from Sri Lanka. People, they have universal health coverage, and people are very clear on, who is responsible for what. So when we visited Sri Lanka, we were told that if a doctor does not show up at a health center for 3 days, people actually start knocking at his door. Why aren't you coming? What happened to you? Are you fine? Are you all right? So we don't have that level of accountability. And the bigger the role the center plays, which it should play actually, there is room for the states to be evasive. Finally, I think because I've been shown the red card. Okay, great. So my last slide actually. So what we suggest in terms of manpower is that there needs to be very little is known about the health workforce in the country. We have no idea who is where, what background characteristics of the health workforce, whatever. So what we suggest, there should be a health census on a regular basis. Then the departments of community, preventive, social medicine should be strengthened, and the private sector should be allowed in them. The faculty should get incentives in terms of higher salaries and greater amounts for research and travel grants and whatever. Full scholarship to all students in the public as well as the private sector who are enrolled in these departments. But then together with that, they should have at least 5 years of primary health center, service, mandatory, whatever mechanisms it is enforced through. Then Ayush practitioners, so there is officially there is provision for Ayush practitioners in primary health centers, but then there is a huge bias against them, and then most of these positions are unfulfilled, so they remain vacant. Then you can have an ASHA type cater. So right now, as Mr. Goel also pointed out, that in Karnataka you have the ASHAs doing the screening. In Kerala they are doing the screening. But then chronic disease cannot become a secondary task of the ASHAs. So right now the ASHA cater that we have is primarily catering to child mortality. We need to have a parallel workforce like the ASHAs for chronic diseases. It cannot be your secondary responsibility that, okay, along with this, you also do this. It cannot be like that, given the burden of chronic diseases. So we recommend that there should be a parallel network of ASHAs for community-based screening and monitoring. Then again, skill initiatives should be strengthened. Thank you very much. Sorry for the delay.
Thank you. So we'll take the questions, in the end that may allow, you to ask specific questions to the speakers, but also have a little bit of broader discussion. So can I hand it over to Professor Mishra?
Thank you, Chairman. Good evening, ladies and gentlemen. I'm here to speak on surveillance, and in fact, for the last 2 hours almost, we have been knowing the relevance and importance of engaging with chronic diseases, particularly in Indian context. So I will actually not give my introduction skipping few slides for paucity of time. I will straight away go into saying what is the significance of surveillance. And in very simple words, I say that whatever we know about something, it is more important to, in Indian context, in every information that we have, we engage in research. More important part, which remains not addressed adequately, is having the right information, who, where, how much, when, details of this. We have information on chronic diseases through variety of agencies. We know today we are able to talk about the extent of it because of that. But going to the need for surveillance, let's say, what is significance of surveillance? It actually helps on the ground that if you have surveillance or a complete surveillance available, you can actually facilitate everything that is required to intervene on it. Otherwise, any intervention, any strategy that we plan will be incomplete. So in that sense, whether we have a right surveillance system in place, whether today is for chronic diseases or in the past for many other ailments, is questionable because of the fact that today we have a surveillance scenario of many diseases which are much, much different from one to the other. There are vertical programs in which there will be better surveillance. There will be situations of others where surveillance will be somewhat like what I say, half-baked. So let me go to say that what is the kind of surveillance on chronic diseases if I go into and find out. They are available in what form, of especially chronic diseases. We have sample registration system, cancer registry is one example, IDSP is another. You have 18 plus demographic surveillance by PHFI, and then you have nationally representative surveys. Now what falls short having all these things is particularly to make surveillance complete, it is necessary that these information that we have needs to be triangulated at a level that we can get an aggregate scenario of surveillance if we talk about population surveillance. And that's which failing in us that we are unable to do. And in fact, I do not see that happening rather than stressing on a kind of a population level surveillance in talk. Coming to surveillance for chronic diseases, which is already, it has been talked about, the national program called NPCDCS. And this is a particular program which was initiated in 100 pilot districts, now has been scaled up to all the districts. Now, whether this program is doing the right thing or not. Actually, in India, we are very good at initiating programs, but we often do not. Even this particular thing, researchers and policymakers have no access to the information that is obtained in this. There has been a scale-up from 100 pilot districts to all the districts, but there has not been a systematic review of this as yet. And that is what will make us realize that what kind of things we have put in place and whether this particular program is doing the job rightly or not can be understood if we first attempt at a review of this. And that is what I see as surveillance under NPCDCS needs to be evaluated first. Coming to the state experiences, as Ali told, that we have actually done this study by considering 4 states, which are in the south, Tamil Nadu and Kerala, in the north, Rajasthan and Uttar Pradesh. And what we actually observed is that we have considered these states because of the disease burden, as we are aware, is higher, because definitely the southern states are ahead in epidemiological transition compared to the northern states. But when something has been done, actually, whether in these states the scheme and action that is in place, we probed in our limited way, and we have obtained as to what is getting done. Only thing that needs to be now evaluated in perspective of surveillance is to compare them, is to see that whether it is done, how much completeness does it attain, what are the best practices, how easier it has been done. I will come in few slides now to show you that what exactly in these states are in place and how much effective the information that is obtained will help in surveillance. When we talk about the NCD indicators, when we take in the available surveys, as I talked to you, that surveillance availability is through the kind of different surveys and other systems. This I give you some information to get an idea about if we depend on the kind of household surveys, the kind of information that we will get, and we have to trust and rely and base upon for our purposes is this, that should we say that these prevalence which we have reported in this large-scale DLHS surveys are sufficient enough? Or will they serve as an input to evaluate any kind of surveillance that we will have, which will be called population-based surveillance? Similarly, you can see this for Rajasthan and Uttar Pradesh, what is the kind of degree? So obviously these 2 tables I am showing to show that what we have chosen as the 2 different regions have definitely, one has a higher burden, one Kerala and Tamil Nadu, Rajasthan and Uttar Pradesh have lower burden. Obviously this is on reporting base and these are self-reported kind of things. So obviously the estimates that we are getting cannot be relied upon to a large extent. Coming to the kind of this program guidelines for reporting information, as I'm saying, is that this is available at CSC, district, state. You have different forms for reporting it. You should see that the differences in person in charge of doing that, then how frequently it is reported and frequency of submission. Though I know that these information are not coming to our hand, I'm still offering you that how is this information, how frequently is it obtained, and what use we can make out of it, if at all it becomes publicly available. Now, if you look at, as Ali was mentioning about budgeting and sanction, yes, on this program, what is the proposed budget, what is the approved budget, and what is the percentage approved actually. If you look at it, in the states where actually the percentage approval is very large, you will be surprised that actually is it happening, this proposed budget approval is getting spent for this particular evaluation. In Kerala and Tamil Nadu, the approved percentage is lower compared to the percentage approved in Rajasthan and Uttar Pradesh. That means you see the money granted is exactly getting spent on this or not is a very doubtful thing if we look at actually the prevalence of chronic diseases in these states. Now I will come to some of the, because we have worked on this paper at length and the state experiences that we have seen, what is the thing, if I pointedly try to put it, the challenges for doing surveillance better is that you have low awareness and strategic focus it loses. In fact, in terms of priority in resource allocation, there has to be an evaluation done as to when resource allocation in health grant is done, whether even with the knowledge of the fact that there is high prevalence of NCD, what is the share that goes for it? Then we are talking of surveillance and we are not talking of the fact that the human resource that we have in place, how much of them can be used, like as Ali was saying, is the second job or it is the first primary job? And it's more important because I know that India's health sector surveillance cannot overlook the private sector. And if we do a surveillance from completely public sector perspective, what amount of information we'll lose out? Will we ever get the cooperation of the private sector in this effort of surveillance? And then role of community health workers, which requires training proper for getting reliable information on things like NCD. Coming down to some of the specific programs, because we did a field work in these states, because we went to Tamil Nadu and Kerala, where you have this public sector initiative, which is there in Tamil Nadu and Kerala, and also in a PPP mode, NGO private sector-led initiative, which are in state of Uttar Pradesh. And these something which we might have missed some of them, but these are some which we could get hold of, and in the paper there is a little bit of details about it as to what are the kind of experiences regarding surveillance which these initiatives are doing. Let me say that if we want to execute a proper surveillance mechanism, what kind of a framework can we use? We can have a kind of a departmental intersectoral coordination to do surveillance, because when it comes to NCD, you have already heard that two issues which are talked of is the magnitude of NCD, the preponement in age in at starting of NCD, so which in a population level surveillance, what kind of the information collection you will do, what kind of analysis recurrently can be done, which will again feed into policy and improve surveillance in a gradual manner. It is never done in one go in any case for a proper surveillance. And this is a kind of a sketch which we can follow if we want to do a kind of attempted surveillance at population level. Surveillance approach we define in terms of many domains when it comes to NCD. Population-based surveillance is just age, which is 30 plus. You can have employment-based, you can have school health program, which is actually limited to school-age population. You can do in many domains that I have actually said here. And these domains will call for interdepartmental, intersectoral cooperation, that they come in for the surveillance at all these domains. And in fact, this will help in making the surveillance complete and also adequately inspected against one component against the other. Otherwise, we will not be able to have a successful surveillance of NCD in any case. So this is just for an example, and in fact, this will help a great deal in terms of intervention as well, because domain-specific interventions becomes better and more effective. Now, a surveillance framework, when we talk of surveillance framework because in the states that we have gone and visited to know the existing surveillance system they have scoring algorithms and surveillance form, the kind of information that they are obtaining now to have a surveillance of NCD. This actually needs to be examined because of the fact that they inform how simplified, how adequate that is to actually get information on risk factors. And if that is true, and that is completeness apart, this is more important how adequate and reliable those information are. And I will show to you examples of few of the forms and content of information collection that is done in the states. And with what kind of workforce do? They engage community volunteers network for cost-effective population-based screening at block level. Then also identify surveillance domains, because every surveillance exercise is happening in a particular domain. This is the form which is done for the state of Kerala. So you have very simple things which is very easy. Risk factors you can get NCD diagnosis, village code. It can be done at a block level. You have household ID. So you have a surveillance which is not technical, which is simpler, but the information could be more reliable. If we go more technical, we may not have the information reliability guaranteed. So this is one form which is used for surveillance. There is an algorithm. This is called NCD risk scoring algorithm. And this algorithm is also, if you take it, of course, it will be very difficult on alcohol use, tobacco use, reporting will be reliable or not, but other information that is taken into in this algorithm, the scores given, will give you an obvious idea, very clear idea as to what is the extent of risk which is there, and we can gradually set population to population the differential risk that you have. And this risk scoring algorithm can be used because what I am trying to emphasize is surveillance more simplistic, more complete, and more adequate. Surveillance more technical, less complete, and we have the current surveillance system, then we should use indirect input for triangulation with population information to estimate rather than going for a population-based surveillance. Now, the recommendation that we actually do reach with this observation that we made in the 4 Indian states is that, in fact, surveillance of chronic diseases cannot be conducted overall overnight in the whole population. It is better to start at a pilot block level because we have this experimentation available in successful places. Try to do it in selected blocks. Try to get an idea that does it really do a kind of an adequate information collection. Then another aspect is very important is that harmonizing surveillance statistics with repeated other alternative information source that we have. And we have enough and more other source of information which could serve as a checkpoint for what kind of surveillance-based statistics is providing for. Secondly, it is also important that in screening and prevention, which are more emphasized in a clinical setting that we want to do screening, it is prevention and treatment activities which is happening. Gender sensitivity in that is very important because otherwise, as you know, even every one of us know that the information on diabetes by male and female, which is actually very clearly shows that actually diabetic prevalence among male are higher because reporting is higher compared to female. So it's because of the current surveillance system. If we want to bring something in place, it should be adequately balanced that this disparity doesn't happen. In fact, for surveillance to be proper, it is better to recruit special staff because this cannot be kind of a supplementary task in the current HRH. The current health resource, the personnel which we have, they are overburdened, it will never work. And actually involving Ayush and private sector partners in surveillance activity is more crucial to make surveillance complete. Because even today, it is very difficult to know the human resource in health in India's private sector. If we want to work on HRH, we have no information. So we know that we are talking of disease prevalence. So when we do not have information on this as well. Finally, I should say that you should require additional community health workers to do this at a community level based on screening and programmatic follow-ups. We have also to say that we have like a public health cadre which we are trying to create. It is an innovation and it will require better expertise to do surveillance of this kind. And then at a primary healthcare level, it is important that a primary healthcare staff, we talk about at a primary healthcare level, what is the number of people who are available at a PHC and what kind of other responsibilities do they discharge? Can they really do this additional task of surveillance? Or the system like HIMS and all that, I know I have been evaluating papers on evaluation of health information system that is put in place management system and how much accurate and what kind of contradiction does it offer. So it is more important that, as I showed the table, domain-specific surveillance will be a better alternative rather than a population-based surveillance, where domains are in charge of that sector. So obviously, from domain-specific surveillance, we will get very accurate and adequate risk factor assessment. Thank you for your attention. Thanks.
Thank you, Professor Mishra. Let's open up. Please raise your hand. I hope there are mics somewhere. Please identify yourself and ask your questions. Also indicate whom you are, which of the speakers you are asking to. So please start. We'll take one round. We'll take by round. So after 2-3 questions, we will give the chances to our panelists to respond, because if it's too many, it may be a little bit difficult. So let's get started, please. Yes. So we will go by table. So we'll go like this in a clockwise fashion. So if anybody in the table has a question, please ask, and then we'll move to the next one. If there isn't anybody, that's fine. We'll go to the next one.
Yeah, thank you very much for this highly enlightening evening. I think it was really a learning experience for me. I just thought that the numbers given are really illuminating, and it is really must be raising the concern of a policymaker. But as a student of economics, as far as an economist is concerned, for me, why I'm concerned about is it is going to cost the economy, the output lost due to morbidity, people who are died. But equally important is, mortality. Equally important is people who are not died, but becoming incompetent of working and contributing to productivity. We have number of studies. I remember in Yale Economic Growth Center, Professor Stools used to do a lot of work in terms of the productivity loss on account of, incidence of morbidity. So I think if we need to impress the policymaker in terms of the outcomes of the study, what we have coming up with, we need to estimate what is the productivity loss in the Indian economy on account of these. First of all, we have to go a little bit behind. Rather than we are concerned so much about people who passed away. Okay, they are in heaven, no problem. But there are people in this earth among us who are not able to contribute. And that's actually adding extra burden in terms of medical expenses. So I think if one can add that dimension, through that we can impress upon the policymakers the relevance of and the importance of the issue that you are highlighting. Thank you very much.
Sudhir K. Jain, Professor, IIT Delhi Management Department. My two questions. One is that Dr. Ali, he showed the figures about China, India, such high, you take any figure for anything, for India and China will be the highest in the world. Okay, they should always be shown in percentage terms, and then only we can say the gravity of the situation. You talk of the road accidents, it will be very alarming. Okay, take anything. So that is one suggestion, and also this thing, you should take care of it. Second is that I think almost everybody in this session, the previous session, many speakers have spoken about the increase in the allocation to the health sector. We should also first diagnose the causes of the diseases. Okay, NCT, what is the cause? The people, the majority of the people who suffer with these NCT, they are living in the conditions, either the slums or in a very, that kind of a habitat, where they are very congested, this thing, somebody is having chula, somebody is having something, smoke is coming, they are inhaling all that smoke, and they are getting, more and more problems regarding health problems. Those are the real issues which are leading to this kind of problem. And by increasing the allocation, I would like to, any speaker can respond. Okay, we say that the total allocation increased 5 times. What do you do of it? Okay, it is increased by 5 times the present level. How will you, allocate that thing to solve the problem? Thank you.
Thank you. I have 2 questions. I am Saxena. I'm a telecom professional and a physicist. 2 things I would like to mention. One is the telemedicine. Have you factored in the role of telemedicine, which creates a tremendous amount of advantage, and you can penetrate very deep areas and get all the details. So telemedicine is one. And then the screening. The cost of these screening equipments normally is very high, but we should work out on indigenous front to bring down the cost so that with little budget we can be very effective. These are the 2 questions. And one doubt which I have about the statistics which was shown by Dr. Uday Mishra. You are showing a breakup of the percentages in which rural and urban are shown separately, and then you are showing the total numbers. Somewhere I find it difficult to really understand as to why the total numbers are close to urban and not to the rural? Because to me that seems to be a sort of a dilemma, because on a weighted average basis, it should be more towards the rural percentage than towards the urban. Thank you.
One more, and then we'll take
Thank you. Dr. Gaurav Sachdev from Indian Spinal Injury Center. Two quick questions for Dr. Mehndi. As a common man, it was difficult to understand when you said government taking initiatives to make lifestyle changes in a person, or obesity changes in a person. And second, as a physician, as a clinician, when you have mentioned treat borderline cases, I mean, with treatment, do you mean medical treatment? Because for a borderline case, as a clinician, I mean, it will depend on case to case. Thank you.
Thank you. Let me give a chance to the panelists to respond to your questions, and we'll try to take another round if we have time. But I was told that we have to stop at 8, and I don't want to stand between you and your cocktails. Thank you. So Ali first, and then Professor Misra, and I'll also give an opportunity to you, Rajan, to respond.
Professor K.G. Joseph, a very relevant point. In fact, most of our data comes from the IHME, and the director of IHME, Professor Christopher Murray, had himself said, why are we obsessed with the dead? Why aren't we talking about the living? But then, I mean, as an indicator, so it's a limited indicator that deaths also tell you about the condition of the living. So it's also about the robustness of the data. Now, in countries where the highest percentage of deaths were happening at the child level, child mortality was traditionally taken as a summary indicator of health. Mortality being taken as a summary indicator of health, because the highest number of deaths were happening at the child level. Now, with the shift in, the mortality patterns, if we focus on adult mortality as a summary indicator of health, that is, now, as Professor Mishra also pointed out, there's a huge issues with self-reported data on morbidity. And I mean, it's just not reliable, especially in countries like India. So you're absolutely correct. We should have better system. Exactly. So we should be targeting at, the condition of the living. But then again, I would like to, to make this a bit more sophisticated here. So, if you read the international reports on chronic disease mortality, I mean, every report will tell you that the burden of mortality is focused on lower LMICs, the low and middle income. So 82% of the deaths due to chronic diseases are happening in the LMICs. So what is the gap between, what is the issue in terms of morbidity and mortality? The progression rate from the contracting of a risk factor to being sick or morbidity to mortality is very high in the case of poor, low and middle income countries. It's very high. You don't even know that you have contracted a risk factor. You don't even know that you have diabetes. It advances to a higher stage, and then you die. And then people say, "Arey, ye to achhe bhale the mar gaye." So, I mean, achhe bhale nahi the. There were issues with him. This guy had issues. He didn't just die all of a sudden. There was something happening at the back. In the case of rich, the progression rate is very slow, as a result of which the economic impact of morbidity is much higher, because people are able to manage chronic diseases. So the progression rate from risk factors to morbidity and mortality, of course, is very slow. So if you look at the economic impact of NCDs, it is very low in the middle and poor countries, middle income and poor countries. The economic impact of NCDs is relatively much lower. The economic impact of NCDs is much higher in upper middle and rich countries, because the progression rate is much higher. They spend a much longer time being in chronic diseases, as a result of which the impact on productivity, the economic impact overall is way much higher. So even without having the statistics, you can easily argue that the impact of morbidity on, productivity loss and, the overall employment is way much higher. Because those who are dying are the poor. They have no economic value. So if a rickshaw puller dies, how do you calculate the economic value of a rickshaw puller? So the people who are dying, so which is why in our report we have emphasized, don't just look at the economic impact of NCDs, also look at the human impact and potential productivity loss. So if this person was alive and if he would have been skilled, if he was given, a position within the Make in India initiative, so to say, what would have been the economic impact? So I think that is where, we also need to bring in the human as well as the economic impact. So totally agree with you on that.